Hello and welcome. Acute pericarditis is a relatively common condition that affects the heart, and it's essential to understand the implications it may have on your overall health. So, if you or someone you know has been diagnosed with acute pericarditis, or if you're just interested in learning more about this condition, then this video is for you. Let's dive in. Acute pericarditis refers to the inflammation of the pericardium, and it can stem from various causes. These include viral or bacterial infections, metastatic tumors, collagen vascular diseases, myocardial infarction, cardiac surgery, and uremia. Acute pericarditis typically manifests as chest pain that can often be sharp and located in the center or left side of the chest. The pain is often aggravated by lying flat or taking deep breaths, and may be alleviated by sitting up and leaning forward. Other symptoms can include a dry cough, fatigue, and fever, particularly if the pericarditis is infectious in origin. Diagnosis is generally made on the basis of clinical findings, though additional tools such as electrocardiography, chest X-ray, and blood tests can be used to support the diagnosis and rule out other conditions. ECG patterns of pericarditis can closely mimic those found in cases of acute myocardial infarction. Acute pericarditis, especially in its early stage, is commonly characterized by elevations in the ST segment, a result of what is known as a current of injury pattern triggered by inflammation of the epicardium or the heart surface. This inflammation usually coincides with the inflammation of the pericardium overlaying the heart. A crucial point of differentiation between ST segment elevations in pericarditis and acute MI lies in their distribution. In an MI, these elevations are typically confined to the anterior or inferior leads due to the infarct's localized area. Conversely, the pericardium's role in enveloping the heart makes the STT changes in pericarditis more generalized, with ST segment elevations often observed in both anterior and inferior leads. An illustration of this can be seen in this ECG, where the elevations occur in leads D1, D2, of VL, of VF, and V2 to V6. Beyond affecting ventricular repolarization, the ST segment, acute pericarditis also has a profound impact on atrial repolarization, which commences during the PR segment, spanning from the end of the P wave to the start of the QRS complex. Notably, inflammation of the pericardium often triggers an atrial current of injury, as evinced by the PR segment's elevation in lead of VR and depression in other extremity leads, as well as the left chest leads V5 and V6. Over time, the ST segment elevations in acute pericarditis may give way to T-wave inversions, a sequence that parallels the one seen in MI. In some instances, the T-wave inversions caused by pericarditis fully resolve over time, with the ECG eventually normalizing. However, there are also cases where the T-wave inversions persist for extended durations. The resemblance between the ECG patterns of acute pericarditis and acute MI, especially with both conditions possibly leading to ST segment elevations followed by T-wave inversions, warrants emphasis. It's worth noting, though, that pericarditis-induced STT changes are usually more diffuse compared to the localized changes associated with MI. Another distinguishing factor is that pericarditis does not lead to abnormal Q waves, as is the case with certain infarcts. This distinction arises from the fact that abnormal Q waves in MI cases are caused by the death of heart muscle and the ensuing loss of positive depolarization voltages. On the contrary, pericarditis typically only causes superficial inflammation without inducing actual myocardial necrosis, which means that abnormal Q waves never result from pericarditis alone. In certain patients, pericarditis episodes may recur or relapse either intermittently or over sustained periods. The corresponding ECG findings can vary greatly, sometimes reflecting the characteristics of acute or evolving pericarditis. The presence of pericardial effusion may lead to low voltage. The mainstay of treatment for acute pericarditis is targeted at the underlying cause if it can be identified. Viral cases, the most common etiology, are usually self-limiting and can be managed with anti-inflammatory drugs such as non-steroidal anti-inflammatory drugs, NSAIDs, or colchicine. In more severe cases, corticosteroids may be necessary. If bacterial infection is identified, appropriate antibiotics will be required. In some cases, acute pericarditis can lead to complications such as pericardial effusion, where excess fluid builds up in the pericardial cavity, or constricted pericarditis, where the pericardium becomes rigid and restricts heart function. These complications may require further interventions such as pericardiocentesis or pericardectomy. Thank you for taking the time to learn with us today. Please share this video with your colleagues, subscribe to our channel, and give us a positive evaluation. We hope to see you soon in our next video.